Thank you, David, and thank you for the invite to the meeting. Before I start, surgical education has always been very dear to my heart. Many of you know that I started a company in 1995 called Proceed, and the goal of that company was to train physicians how to do prostate brachytherapy worldwide. And I did that for 15 years. I can remember the first year I was really involved with that program. I traveled 242 days training physicians on site. And of course, yeah, no one's going to even come close to doing that today. So the surgical education, or all education, needs to be done more efficiently, and hopefully what I'm going to show you today will give you some idea where I think we're heading with this. I only have one disclosure, and that's VMRS. VMRS was co-founded by my son, Jonathan, and I. Jonathan is a neurosurgeon at the University of Rochester, and some of the technology I'm going to show you comes out of the University of Rochester, and I am Chief Medical Officer of this company. So let me give you the background as to why we're doing this. So AI is a wonderful technology because it can help humans perform things with machines or computers that we can't do on our own, or we can augment what we do. Artificial neural networks and machine learnings are subfields of AI, and you need the data using these two subfields to train the computer, or if you want to call it the artificial brain, to do complex tasks such as reading radiographic images and interpreting pathology. And you've heard at this meeting that that field is probably going to progress very rapidly. Not that it's going to replace a radiologist or a pathologist, but it's going to supplement them, so perhaps they will make less errors and become more efficient at their tasks. While we started to integrate AI into urology, it's just beginning, and we're starting to see such opportunities as identifying gene signatures for bladder cancer, determining biochemical recurrences after prostatectomy, and urinary continence recovery. And these have all been reported in the literature as burgeoning fields. So let's frame the issue regarding surgical education. Surgical education requires that a trainee gain clinical experience by directly working with a skilled instructor. When I was a resident, we worked by the Halstedian see one, do one, teach one. And that no longer applies today because we're really learning to operate complex machines which require significant onboarding before we become experienced with that. Also with surgical resident education, because a resident is not going to get adequately educated in the OR unless they're there enough times for a specific surgical procedure, and that doesn't always happen. So that's often been termed education by random opportunity. If you don't get the experience because you're not there, you're not going to learn adequately. And there's another component to this. Even when you're with an expert learning a procedure, whether you're a resident or you're now an attending and you're learning to operate a new robotic machine, for example, your trainer may have limited experience in that particular field, so your education may not be sufficient to get you adequately familiar with the technology. So how can artificial intelligence improve training? Well, we can think about it as maybe AI can replace the proctor. And in this scenario, the AI, or the artificial autonomous brain, can train the individual. It can observe what you're doing, and it can correct you if you're making a mistake or about to make a mistake. In order to accomplish this type of work, we first need to develop a strategy and programs where we can practice outside of working on an actual patient. So I would recommend, and this is what we're doing, we develop the programs and we practice first on phantoms outside of the OR, and once you get the ability to show that that actually performs well, and performing well for an AI program means you gotta get to a level that's 98, 99, 99% correct. which we can't do right now. Let's recognize that, but that's where we got to get to. And we need to first show that on a phantom, and then that could be followed by introducing this technology into live surgery. So what are the requirements? So this is more or less a home-developed system as how I and my colleagues see how this field should move for this particular aspect of artificial intelligence. First, you would need an extended reality headset with see-through optics. So this is not virtual reality. Today, we're very familiar with using VR to help us augment surgery, but when you wear a VR headset, it's a blackout screen. So it removes you from the real world. And when you're a surgeon, you have to see the real world around you. So you need a headset that allows you to see something in front of you that's training you, but at the same time, you have to see what's going on in the operating room. So that's technology that's just beginning to come out. Some of you might be familiar with the Apple Vision Pro, just released. Looks like a pair of ski goggles. The issue with the Apple Vision Pro, which is see-through, is it got 6 cameras in front of it, and the cameras are recording the environment and then projecting it on you into your headset. So you're actually not seeing the real world, you're seeing a projection of the real world. So that, even though people try and adapt that for this particular application, it's really not going to work correctly. The next component you need is what I call a closed-loop system. Something needs to be watching what you're doing, recording it live, feeding it into the AI programs, and then spitting it back to you in a corrective measure. So you need a first-person camera built into your equipment to actually see what you're doing. And lastly, since many of us do a lot of image-guided surgery, in addition to the live surgery, you have to be able to take the image guidance, put that in your eyes, and then look at the operative field while it's in your eyes. So you can't be like this. Doing a procedure is what we all do today. You have to be looking at the surgical field and have that vision in your eyes live. Not a hologram, but live images. So those are the requirements we set out to achieve. And this is just an example graphically of how it all puts together. This is actually Dr. Ken Langer, a urologist from Baltimore, who's wearing the headset. So this is the headset. It's got a first-person camera in it. And you see that the ultrasound image is over here behind him. But he's not looking at the ultrasound image. The ultrasound image is here in his eyes. It's being projected on clear see-through optics. Those optics were made by a company in Israel. And that ultrasound image is displayed on top of the phantom. So he sees the image in front of him while he's pushing the biopsy needle into the prostate phantom. So this, as a proof of principle for the actual hardware of the system, works great. That collects the information, feeds it into the machine learning engine. Then you have log files, which log files are basically individual states. So that means if I put a needle in this way, that's correct. That's a state. If I put the needle in this way, that's incorrect. That's another state. So you have to collect all those states, which are collected by the headset. Then you create the program. That's fed into another program that processes the information that's flowing through the headset and then feeds it back to the surgeon with a corrective measure. So that's what I call a closed-loop system. Now I'm going to show you a very short video of how this works. This is Steve Griffith. He's the chief engineer for the company. He and I built this program for placing a needle into the perirectal space in anticipation of inserting a rectal spacer. This is just built for proof of principle. It's not a program that you would put into clinical practice. So the first part of this video, it's a very short video, was a third-person camera looking at what Steve's doing. The second half of the video is an image from what he sees in his eyes. So you'll see here the computer, which is giving the written and audio instructions for Steve, who's never done this procedure. There's the ultrasound image back here from the phantom and the prostate ultrasound. And these two are put together, projected by the mini projectors in the headset, displayed in his eyes. And while he's performing the procedure, he's also able to look at his hands. Because remember, it's not a blackout screen. He's seeing the real world behind him. So let's just play this real quick.
Apex and rectal hump. Angle approximately 7 to 8 degrees downwards towards the posterior side of the prostate. Insert needle between prostate apex and rectal hump. Angle approximately 7 to 8 degrees downwards towards the posterior side of the prostate. Needle inserted correctly. Bevel at target position. Bevel down at prostate base. Select transverse imaging plane. Transverse selected correctly. Confirm needle position at midline in space between prostate capsule and rectum. Needle. Reposition needle to prostate midline. Confirm needle position at midline in space between prostate capsule and rectum. Needle placement confirmed. Switch to sagittal imaging plane. Sagittal selected correctly.
That's it. I got 100.
Intro to spacer training platform. Select sagittal imaging plane. Sagittal selected correctly. Insert needle between prostate apex and rectal hump. Angle approximately 7 to 8 degrees downwards towards the posterior side of the prostate. Insert needle between prostate apex and rectal hump. Angle approximately 7 to 8 degrees downwards towards the posterior side of the prostate. Needle inserted correctly. Position needle bevel at prostate base. Bevel not at target position. Bevel at target position. Ensure the red marker on the needle's hub is facing upwards. Select transverse imaging plane. Transverse selected correctly. Confirm needle position at midline in space between prostate capsule and rectum. Reposition needle to prostate midline. Confirm needle position at midline in space between prostate capsule and rectum. Needle placement confirmed. Switch to sagittal imaging plane. Sagittal selected correctly. Apex and
In conclusion, AI-generated programs can augment training of surgeons and may provide an opportunity to reduce errors in the OR by observing procedures. I'd like to also invite you to our Southwest Prostate Cancer Symposium meeting in October of this year. We have a whole session dedicated to AI. In addition, we're going to have hands-on training for prostate procedures on one of the mornings. Thank you very much, David.
we've had a lot of discussion on artificial intelligence, and same, branching off my comments this morning, one of the issues of the robots is accountability. We had several abstracts at our section meeting that showed that these robots at times hallucinate or kind of make stuff up, and they do it with authority. They don't say, like, I'm not sure, they just start spitting out stuff. So you do wonder about, using them to write papers. I worry less about training, but you have to still wonder what happens if the robots make mistakes. Probably a bigger issue on that pathology exam where, where's the accountability if a path grade is done wrong by artificial intelligence. Then, love your comment, but let's comment, my younger daughter's a Vanderbilt law student. They're taking whole classes on artificial intelligence in the law. So remember that law schools are teaching that because they're very interested in this.
Yeah.
Yeah, a quick comment, John, you're absolutely right. This is just the beginning. This is not a process that's going to happen in a few years. This is going to take 10, 20, God knows how many years to get right. And one of the issues with AI is, I think everybody appreciates, is it's only as good as the data you feed in. And then that data is always suspect unless you're doing it in advance. So what we're trying to achieve here is using the headset to watch what's going on and then record enough information where you feel comfortable, whoever's doing it, that's enough data, visual data now, and it's going to be in 3D because that's the next generation, because you can't really record open surgery in 2D and ask the machine to train you when you're working in 3D. So it's going to be 3D, and then it's one of the issues I feel very important about is it needs to be tested outside of the OR on an appropriate artificial system such as a Phantom. And then you go to the next level, but this is a really long-term process.